Hey guys, it's Matt. I am a program specialist with Task and Ship here at the National Rural Health Resource Center. This is a pet project of mine, telehealth, anything to do with telehealth, I'm very passionate about. So we are very excited you are here. On the screen right now, you can see our team, your task team, and they are all present today. Looking forward to a great presentation and interaction from each of you. We do want you to interact. That's going to be said multiple times. I will be monitoring, as well as Caleb and the rest of us will be monitoring the chat box. So feel free to put it in there or come off mute, whichever you prefer. Let's see here. So we've already launched the pre-poll, and then we have opening introductions. We'll hear from Terry Hill in a second, and then we will present to you the Critical Access Hospital Telehealth Guide. And Trudy Bearden and Nikki Parisha will share with that, as well as Kim Mayo will share information about a kind of a case study from a hospital system. Afterwards, we will have a post-poll and Q&A session. So that's just kind of a run through of what's going to go on. At this time, we are going to drop the link in for the telehealth guide itself. I think Nicole's going to take care of that. So if you do not already have the telehealth guide downloaded or up on your screen, you are more than welcome to do that. Jalen also just copied it in there. And so feel free to do that and follow along as necessary. So at this time, I'm going to introduce Terry, who is also more passionate about telehealth than I could ever imagine and knowledgeable. As you guys know, Terry is the Executive Director for the Rural Health Innovations, and he is a Senior Advisor for Rural Health Leadership and Policy for the National Rural Health Resource Center. Afterwards, you will hear from Trudy. And Trudy has served as a senior consultant for CoImagine Health since 2010. She's leveraging her experience as a clinician in the primary care and inpatient settings to deliver consulting and practice facilitation skills. Ms. Bearden also provides intensive and comprehensive healthcare service delivery technical assistance on a broad range of topics and issues, including telehealth, which she has done here magnificently. Working with teams to improve quality, safety, and efficiency. She has an additional strong expertise in telehealth, in panel quality improvement, care management, population health management, customer and person-centered service, project and change management, EHR, and workflow optimization, and team dynamics. Then we will hear from Nikki Parisha. Nikki serves as the program director at the Northwest Telehealth Resource Center, creating and disseminating information and resources to expand and sustain telehealth in the NRTRC's 7-state region, serving Alaska, Idaho, Montana, Oregon, Utah, Washington, and Wyoming, and beyond. She is an invited speaker across the country, sharing her deep and broad telehealth expertise in ways that resonate with participants, including a focus on telehealth's critical role in achieving the quadruple aim of reducing cost, improving quality, enhancing the patient experience, and bettering the work life of healthcare staff. And with that, all three of them have way more qualifications than I could ever read off in an hour. They are amazing people who have been a tremendous blessing to work with through this entire process. And with that, I will hand it over to Terry. Terry, you'll be introducing Trudy when you're done.
Thank you very much, Matt, and hello, everyone. First, I should note that TASK and this project, this guide, is funded by the Federal Office of Rural Health Policy. And they have been involved every step of the way, giving feedback to us. I want to express appreciation right up front. It's not news to any of you that there's been a dramatic growth in telehealth with the COVID pandemic. Telehealth was already growing very rapidly, but it took major leap forward as we were basically providing care to folks in their home. And today, even though there's been somewhat of a reduction down to what I see estimates at 20 to 25% of the primary care still being provided that way, and a lot of the care just in general, still a rapid expansion. So TASK has been involved to some degree in the past through our National Rural HIT Coalition, which includes telehealth. But as we looked at the need perhaps for more support and more resources for our flex programs and possibly our critical access hospitals and rural health clinics, we first went to the Office for the Advancement of Telehealth and to FRHP because we did not want to duplicate any of the good work that is currently going on there. And there's just a lot of good work going on, new educational resources being provided. I'm on one of their work panels of the TRCs that are creating resources for rural health clinics, and they've got a lot going for critical access hospitals as well. We particularly met with Mike McNeely and a few of their folks and said, hey, our perception here is that we could probably use more help with the flex programs. We've received some feedback that many of them are not quite sure how to position themselves or how to support their rural hospitals and clinics. And another thought was that there may not be enough resources out there for critical access hospitals and rural health clinics. And in that regard, our flex programs are perfectly positioned to help get resources out there and help connect our hospitals and clinics with the TRC in their area. So Mike gave us the go-ahead on that, and we decided within TASC, first of all, to expand the number of our HIT coalitions. Nicole Clement has been working really hard on that and helping basically. So now we're holding them every other month. We put on a series of webinars as well. And then as kind of final piece, we are in the process of helping to kind of send out a telehealth resource guide for critical access hospitals. So, that means that we're doing education, we're increasing the coalition, and we went through a competitive process to find an organization that could put this guide together, because Nicole, Matt, and I, even when we're together, don't have that level of expertise. We chose the Northwest Regional Telehealth Center for a variety of reasons. First of all, they put a really good proposal together, but the second reason is they had experience. Matt McCullough, who many of you know, is leading that organization. So we've always thought highly of Matt's work. We were introduced to Nikki and Trudy, and both of them have a strong background in working with critical access hospitals and with rural health clinics. So that basically is the background. They have produced the guide that I am really impressed with. I'm excited about this. I think it's something that is going to be relevant and useful for our state flex programs. And I also think it's a guide that can be very, very helpful for rural hospitals and rural health clinics as well. So kind of with that introduction, I'm going to turn things over to Trudy, who is going to lead the presentation.
That was a great introduction. Thank you so much for that. And I have about 25 minutes, so I'm going to breeze through slides and really quickly and get to kind of showcasing the guide a little bit. And I have worked with critical access hospitals across the country and worked with several in the state of Idaho. I'm a physician assistant. I've practiced rural family medicine. I've been the manager of a safety net clinic, and I have worked in the inpatient setting. However, it was not a critical access hospital, and I just have loved doing this work. And I have to say the partners along the way for this journey have just been amazing. So today we're going to talk just a wee bit about how we got started, a little bit about how the content got developed, and some of the things that we have to think about with regard to updates going forward. We really want your feedback. So this is the first time we're having outside eyes take a look at this, And the wisdom of the crowd is always the best. And as you know, you grow expertise by getting feedback from people who can critique your work and give you feedback. So we want feedback, tons and tons of feedback. We'll go over the table of contents. Hopefully it won't make your eyes glaze over. Keeping in context that the majority of you are Flex program coordinators, and how can you use this guide to guide how you're helping the critical access hospitals, especially with implementing, improving, and sustaining telehealth. We feel that one of the things that we've done a little bit differently with this guide is actually talk about what are the billing codes for telehealth. So people talk about telehealth in very vague terms, and we know that telehealth has to be described by billable codes with services and other additional details. So we've put together a coding table that you may be able to use perhaps a webinar with your critical access hospital. We also created a telehealth program assessment that we hope is very practical and easy to use telehealth program assessment. And then we will review some of the NRTRC resources if time permits. So partnership, it has just been an amazing partnership, and we really don't want to go any further without acknowledging HRSA and the Federal Office of Rural Health Policy, or FORP, and the Office for the Advancement of Telehealth, or OAT, for funding and for supporting both the NRTRC and the center. So it was this great partnership. We kind of got our marching orders for the Critical Access Hospital Guide in very well articulated expectations. They said, you need to put these things in there. They have to be in there. And then we had to struggle with, what do we do with public health emergency related information? So we had to have a solution. And for the most part, things that are public health emergency related are in gray boxes to call out that this is not permanent. You know, we expect the public health emergency to last until at least December 31st. So we might be doing some updates pretty quickly. So that content development was based on those specifications that I mentioned, geared towards practicality and minimizing what we would call TBU, or true but useless information. We were limited to 60 pages. So 60 pages is long for a guide. 30 pages is long, but there's so much to put in it. And so we had to, I think we might have gone over by about 6 pages or so. We had a lot of subject matter experts who weighed in and provided additional feedback. We had to be clear that for a 60-page telehealth guide, it couldn't possibly be an all-inclusive policy guide for telehealth. And right around the corner is the final rule. So the final rule is going to be published in November, and there are a lot of things in the proposed rule that are going to impact the information in this guide, especially for our rural health clinics. So give us feedback. What's helpful? What's not? Is there missing or incorrect information? What resources did we miss? I mean, when you see the guide, if you haven't already checked it out with the link, there are a bazillion hyperlinks to resources. What else? So chime in, so raise your hand, just speak out, chat your thoughts in, or you can always let us know at info@nrtrc.org. All right, so we covered Genesis, content, feedback. Next, we're going to cover the table of contents. We're going to cover that table, and we're going to cover the assessment. So this is what the table of contents looks like. It makes you your eyes glaze over. I know, but hang on just a second, and we'll actually show you the guide and do a quick sashay through the table of contents, touching on particular topics. We will take a look at that table. We'll kind of show you the assessment. It's pretty simple. It's a full 22 pages at the end of the guide. So the guide with the assessment is 88 pages long. And what I'm going to do now is, okay, let me know if you cannot see my screen with the table of contents.
We can see it.
All right, great. Thank you. The table of contents is hyperlinked, so you just click on a topic and it'll bounce you to the topic. It starts with a brief introduction, talks about the potential of rural telehealth, which we know is huge. Nikki and I were talking to a critical access hospital that is in northern Montana, and it saves their patients hours and hours of driving. They joke that they're closer to the border they're closer to Canada than they are to a Walmart, and they're even farther from specialists. Patients have to drive so many miles. There's the telehealth basics, and I think that might be helpful for the Flex program coordinators. I saw on that poll that you guys are actually already pretty knowledgeable, so you have a working knowledge base when you head into this. Medicare kind of sets what everybody else follows, I think, for the most part, and they have a set of codes. So they are Category 1 and Category 2 codes that they publish every year. And they add codes as part of the rulemaking process. And Medicare, what Medicare does is really easy to get your hands around. It's clearly articulated. They have a nice MLN fact sheet. They have additional documentation. But then each state is different for Medicaid. So if you are in a state and you want to know what are our options for telehealth in our state, the Center for Connected Health Policy has a state-by-state kind of outlines what the state Medicaid does and does not do with regard to telehealth. So Medicare, for example, prior to and after the public health emergency, has over 100 Category 1 and Category 2 codes, but each state Medicaid chooses their subset of those that they will reimburse for. There's a couple of states that reimburse for the entire set of codes, but those are kinds of things that would be helpful for you as a Flex program coordinator to know what's what in your state. And if you go to the Center for Connected Health Policy, if somebody can pop that link into chat, that would be great. You can click on your state, and then within clicking in your state, it links you to the statutes for your state, which is really helpful. And then, of course, there's the private insurance. And private insurance is all over the place. Some states mandate a little bit what private insurers have to do with regard to telehealth, whether they have to have payment parity, whether they have to have coverage parity, all those kinds of things. So that section might be helpful. I think it's also important to keep separate telehealth services delivered as a distant site and telehealth services delivered as an originating site. And we find that most critical access hospitals are delivering telehealth or providing telehealth as an originating site. So patients will come to the critical access hospital and they will take their telehealth visit with a specialist who is somewhere else at a distant site. And the reimbursement is small for the originating site. Medicare does reimburse it for critical access hospitals. Each state Medicaid, you never quite know. You have to look up whether they reimburse for that originating site fee. But then for the distant site delivery, that is where the hospital or the rural health clinic actually can deliver telehealth as a distant site. RHCs have only been able to do this since the public health emergency, but there are so many pieces of pending legislation that are going to make this permanent, because I think everybody sees the benefit that we should be thinking about what the options are. And in that table that I'm going to show you, we've included the codes and the current national reimbursement rate. And it's a good platform for talking to specialists, because if you want a specialist to provide telehealth, it's good for you to know, what's the business end for them? If you're going to do an interprofessional consult, for example, which is a virtual service, the reimbursement is so tiny that they're probably going to say, yeah, no, we're not going to provide that service to you and your patients. So the telehealth basics is a good section. The virtual services may or may not be of interest to you. So it's kind of an extension of telehealth, because telehealth, like I said, is limited to that set of codes, and you have to have interactive two-way communication and all those other things that Medicare specify as telehealth. But there are other options for serving our patients in remote areas that are not telehealth per se. Scrolling, sorry for your eyeballs here. You'll hear a little bit later from Tippah County Hospital. You'll hear about how they were so successful. And let me just say, when we interviewed them to learn a little bit more about their telehealth journey, they and their leadership were all in. Like, they are going to succeed. We were so impressed by them. Engaging key stakeholders. So what are the stakeholders that you might want to talk to? Are you going to talk to the school? Are your vendors going to be your stakeholders? Are you a county-owned critical access hospital? Do you need to get the county involved if you're going to make changes with telehealth? So we put together what we think is a good table, but if you see in that table, oh my gosh, they missed the boat, there are these other stakeholders that need to be included, let us know. We can put that in for future iterations. And some tips on how you go about engaging the key stakeholders. So if somebody's just starting out, what are some of the tips with communication, et cetera? We have a short section about initial steps to begin or to reassess your critical access hospital telehealth program. If you haven't selected your vendor yet, some vendor selection and guidance tips. I think that some critical access hospitals are really keeping it simple. So what I heard from one critical access hospital was that they just went with Zoom because that's what their staff were used to. Their staff were used to doing meetings by Zoom. So, hey, let's just do telehealth by Zoom. We'll just get the HIPAA compliant version of it and make it easy for them. And, this statistic is attributed to various people, but only 30% of changes often stick. So it's telehealth at your critical access hospital that you're assisting. Is it kind of a flash in the pan during the public health emergency, or is this something that you're going to adopt and sustain? And there are some key factors to consider, that is for sure. Person-centered telehealth, we're hearing that term so much now, patient-centered, person-centered, and person-centered is not just about the patients, of course, so it's about all the staff that are involved, so making it as easy as possible. When Nikki and I were talking to that critical access hospital in northern Montana, they have a paper packet for staff that has all the details of all of their specialists that they do telehealth with, and so it's really person-centered from a staff standpoint. But there's engagement and education with patients, health equity. There's kind of that section on health equity is pretty huge because if a patient is not coming to the hospital and they're in their home, their home is the originating site and they are receiving services, they have to have a computer, they have to have reliable internet, they have to have a camera, they have to have a mic. As Nikki points out, sometimes they need to have an email address. So, what are the barriers and potential solutions? And honestly, I will say that some of the rural health clinics that I have talked to have had amazing solutions for these, like grant funding to use iPads that they actually bring to patients. Amazing. So communication and support is really important. And I think if we could kind of rejigger this table of contents and put the most important at the top, you might see workflows at the top. We know that it's workflows are so important. We have a resource with some workflows, but each organization is different. Billing and reimbursement is key. People always ask about documentation, so we included that. During the public health, so I'm going a little faster because I just looked at a time check and I have about 10 minutes left. So I'm going to go a little quicker. It's my passion, and if you'd let me, I'd be here until next Tuesday. So, with a public health emergency, we can actually have a virtual team. So you can have a medical assistant or a nurse that is at home and is participating in a telehealth visit where the patient might be at the hospital or might be in their home. So what are the virtual team considerations? There are care coordination options with telehealth and care management. So example, the transitional care management codes, which CMS just bumped up reimbursement for, are a telehealth code. And, we want to reduce those 30-day readmissions. This is a great way to coach your critical access hospital for how they can do reimbursement. Telehealth, it may not work out for them, but it's worth looking into. QI and QA are also very important. there are some legal and risk management considerations that keep me up at night. So we've covered some of those. Honestly, in the primary care setting where people are doing telehealth, they've kind of lost their workflow where we have team-based care and our team is looking at who's due for what ahead of time. Doing pre-visit planning seems to be falling by the wayside. That's actually a risk management issue because you can have missed and delayed diagnoses. HIPAA is huge. You know, I have worked with critical access hospitals across the state of Idaho, helping them with their HIPAA required security risk analysis. And you're required by HIPAA, if you're going to have a new platform, if you're going to be having new devices, this all needs to go into your security risk analysis and you need to reevaluate it. Rules, regs, and keeping current. And then we have resources to bookmark. So let's see if I can bounce us to that table. And that's not bouncing me there. So what I will do is, sorry, look away while I scroll. You know, it can be really distracting. So here's the code summary table. These are the category 1 and 2 telehealth services. There are interim codes. So there's over 100 interim codes. Those interim codes are only for the public health emergency and will no longer be able to be used after the public health emergency ends. There's also a slew of category 3 codes that were added as part of the public health emergency. It's a new category of code, and those, if the final rule ends up like we expect it to, those will actually be available through 2023. So this is a long table, so I'm not going to go into it in detail, but these are some of the codes and reimbursements that can be performed by telehealth. So this, we've grouped them. So, you know, I don't know that anyone else has done this. And I, on my part, I am very proud that we did this and I hope it's useful. I have great expectations. So we've grouped them. So for hospital, critical care consult, and nursing facility services. What are the codes that are on the list? Post-discharge services. So we have the transitional care management, and you can see the reimbursement is actually very high. CMS has increased the reimbursement because there was low uptake of these codes, and they are really key to reducing 30-day readmissions. There's the E&M visits, and as you know, we have time-based E&M codes as an option. So scrolling, chronic kidney disease, end-stage renal disease. As you know, this is a huge cost issue for Medicare and Medicaid, Medicare primarily. Behavioral and mental health. There's a lot of those codes. Substance use disorder. So these 3 codes, for example, were new for 2021. So there's this whole tool set for codes. All right, so I'm going to scroll down a little quicker. These are the potential workflows, and I'm just going to scroll to the telehealth assessment. So we've tried to keep this really practical and not fussy. So, you know, sometimes when I look at other telehealth assessments, it says, you know, have you performed your market analysis? You know, and honestly, I think that understanding what your community's needs are for telehealth and then meeting those needs is most important. So, you know, it starts here with organizational readiness, and it follows a maturity model. So the salmon color is kind of, you're at the base levels. The yellow is where you're a little more advanced, and the green is the most advanced. And this is something that you could, I find that these types of assessments work best when they are facilitated by someone like you, like a flex program coordinator. So you walk them through it. You can kind of, you carve out the time for them to do it. You get the team together, you discuss it. Somebody on the side can start keeping notes of like, hey, we need to dive into this a little bit more. And at the bottom, I'm going to spare you. I'm not going to scroll all the way down to the bottom, but as you click off the numbers, it'll self-score for you. And I think I downloaded this and saved it in the wrong format, so I'll have to sort this out. But the links that were provided to you in chat, if you download this, it will work. And if it doesn't, let us know, because these can be tricky forms. All right, so I think with that, I'm going to take a second to check chat. All right, so we have some links.
We don't have any questions in the chat at this point.
Okay, and somebody private chatted to me that they were only seeing the table of contents. Was that and I didn't see that probably at the time when I was supposed to. All right. All right, so that's all the time that I have, and so I want to turn it over to Nikki and Kim. And thank you so much for hanging with me there as we switched screens and scrolled through a PDF.
Thank you, Trudy. That was great and very condensed. So appreciate you going through that. And any questions you all have while you're reviewing it, while I'm talking about some of the resources the NRTRC has to offer, feel free to throw them in the chat. I just want to echo what Terry and Trudy and Matt all shared. This has been an amazing project. And I want to share a little bit about the Northwest Regional Telehealth Resource Center and also let you all know how to contact your regional telehealth resource center. So the NRTRC is, we are actually federally funded through the Federal Office of Rural Health Policy and HRSA and OAT as well. And we are housed within the Utah Telehealth Network in the University of Utah. I'm going to share my screen here. And if you all have questions during this, please throw them in the chat box, and I will try to address them as I go. So as I said, we are federally funded, and we are here to provide technical assistance around telehealth. Really, our vision is to advance the development, implementation, and integration of telehealth. And help with the sustainability, provide technical assistance to not only providers, but patients and administration. So here at the NRTRC, we are in this corner. So we cover Alaska, Washington, Oregon, Idaho, Montana, Wyoming, and Utah. However, as you see this map here, this is actually the National Consortium of Telehealth Resource Centers. We are one of 11 regional telehealth resource centers that make up the national consortium. So every state has a designated telehealth resource center. And by going to the NCTRC website, you're able to identify the telehealth resource center that supports you. That being said, this guide, we are happy to support or answer questions to any of you all, regardless of the state that you're located in. So definitely feel free to use the email address at the beginning of the guide. Along with the 12 regional telehealth resource centers, there are 2 national centers, and Trudy mentioned the Center for Connected Health Policy. This is like, this is my speed dial on my internet. I mean, they are the experts on policy and reimbursement, and they are up to date on almost all of the changes. And within the last 18 months, there have been a lot of changes. So that is an amazing resource, along with it's called TTAC, the Telehealth Technology Assessment Resource Center, which can answer your questions on telehealth vendors, platforms. They're agnostic, so keep that in mind. Really quickly here, I just want to also share some resources that may be helpful for you all as Flex program coordinators as you start to utilize the guide and potentially have questions, or the staff at the Critical Access Hospital or Rural Health Centers have questions. Our website is nrtrc.org, and we have created some education, some online telehealth education and resources and tools. We have a couple courses here that are fantastic, fairly high level, but address many areas of telehealth that are important in terms of implementation, sustaining, policy and reimbursement, workflows. This NRTRC Telehealth 101 online training covers all of those areas. There are 6 courses within the module. These courses are free and available to anybody. It's on a learning management system called Canvas, and many of them have CMEs associated with them. There are a couple of other courses that if anybody wanted to dig a little deeper, there are some specific for telebehavioral health and also VA and telebehavioral health, and then providing telehealth to geriatric and long-term care services and primary care. As Trudy had mentioned, I know that this guide is available under resources on the NRTRC. There's a section for the Critical Access Hospital Telehealth Guide, along with all of the resources in the appendices that Trudy had mentioned. So I'm going to cut my time a little short just so I can hand it over to Kim, and we can talk about TIPA and the Critical Access Hospital from Mississippi and their model. And I do want to leave some time at the end for questions. So I'll go ahead and throw our website and my email in the chat. I believe it's on the guide, but that way you all have it if you need it. And I'm going to hand it over to Kim.
Thank you so much, Nikki. I appreciate that. And it is really a pleasure to be here with you all, and just want to throw my hat in the ring. I'm also very passionate and excited about all things telehealth. I am a program specialist with the DRCH SD program, and my focus area is telehealth and outreach. And it really is a privilege to be here today to get to share with you all about the success story of TIPA County Hospital. So TIPA County Hospital is a county-owned critical access hospital with that also has a rural health clinic, and it's located in Ripley, Mississippi. So Ripley is in the northeastern part of Mississippi. So in 2017, TIPA was selected to participate in the Delta Region Community Health Systems Development, or what we call for short, because it's really not that much shorter, but DRCH SD program. And that is through the support of the Delta Regional Authority and the Health Resources Services Administration's Federal Office of Rural Health Policy. So the National Rural Health Center, the National Rural Health Resource Center, provides the selected healthcare organizations and their communities with the technical assistance through this DRCHSD program. And through the program, our charge is to assist leaders and providers in identifying and addressing healthcare needs while strengthening the local healthcare system. So that's a little bit of background to set the stage and provide a little bit about TIPA and the telehealth journey. They, in previous years, they had been unsuccessful in implementing a telestroke program in their emergency department. So they'd had that experience behind them, but as they began the DRCH SD program, a part of that program is a telehealth assessment. So through the recommendations from that telehealth assessment and those action plans and a stoplight report which was all completed in 2019, they began their process of implementing and expanding telehealth with a couple of goals. So the thought was to increase telemedicine to fill service gaps and access to care, while enhancing coordination of care and developing a community care coordination plan, and all the while strengthening the local healthcare delivery system to position for population health management. So TIPA worked on their telehealth implementation planning and preparation through the latter part of 2019 with a launch date of February 2020. Well, I think we all know what happened about that time in history. And because of their work and the preparation that they had done, and they were able to set up a telehealth within hours of the COVID-19 shutdown, as we all know. So this is what I like to call their first success. Because they were positioned for this, they were ready to implement and begin telehealth before they were actually targeted to go. So that was a huge success. And the key to that overall success was and truly is their leadership, and how their leadership has endorsed and engages with them. So a quote from their CEO, which kind of tells it all, is as he says, telehealth is the future of healthcare, and we must prepare or we will be left behind. We all know that, but for a CEO to say that, that's pretty profound and pretty powerful. And that just kind of shows you where the mindset of TIPA County Hospital was at this time. So another factor to their success is that telehealth was integrated into their strategic planning. And as a result of that a department of telehealth was developed for the hospital. And so with all of these great, telehealth plans, it's not surprising that you must have a strong IT director and a capable and engaged IT staff. And TIPA had that, and that was a big asset to implementing telehealth. So as they trained staff, their trainings were tailored to the users, tailored around the equipment and the workflows. I think if I've heard one thing today, I've heard workflows and how important those are. And so according to their director of quality, risk, and compliance, these scenario-based trainings make staff comfortable. It eases anxiety and also helps them to learn how to troubleshoot on their own. And that reinforces its staff, and not only reinforces staff, but they're comfortable with technology and the workflow, and they will not use it. And we all know that if we don't know how to do it, the likelihood that we're going to try it is not great. So TIPA was successful in their telehealth implementation because they took an inclusive approach. They held group project meetings with key stakeholders, asking for their input and asking the simple question, how will we do this? And then as more people were added along the process, and as they came together, and the teamwork is what launched the telehealth program. And so all the while all the planning was going on, TIPA knew that the program would need continual improvement driven by feedback and input from their end users. So TIPA collects a variety of data, such as number of telehealth visits compared to other visits, canceled visits, and then of course random surveys. After each visit, TIPA asks the patients if they would rather do a telehealth visit again or go back to an in-person visit. And so far, only one patient has indicated they would prefer to go back to in-person visits. TIPA has expanded their healthcare services by telehealth by partnering with specialists and acting as an originating site. No surprise that pain management is has resulted in one of their most popular, I don't know if that's the right word, outpatient visits. You can see on the screen here on the slide, the other specialty services are listed as well as a brochure that was developed. That's just to educate more on telehealth. It's a great resource as well. So because of this success, they were able to hire a full-time telehealth program manager. And this was an internal promotion of an RN who had some paramedic experience. So building on their experience, skills, and interest, they're currently exploring telehealth in their ambulance service and currently in talks with the local EMS director and to move forward with that project as well. TIPA has expanded telehealth to their med-surg and swing bed units. their staff, if they have staff that are not on site, they're able to conduct telehealth visits on the med-surg floor. So this helps with not only provider fatigue, but also cuts down on exposure of COVID and conserves PPE as well. So TIPA is actively working to partner with specialty services for their inpatients, which will allow them to keep more patients in their facility rather than transporting out to the community. TIPA has also expanded their intensive outpatient psychiatric program by allowing providers to see and treat outpatients by telehealth either in a group format or individual sessions, which can be in the patient's home or in their nursing homes. So if all of that's not enough, based on their progress and their successes, they have identified future growth and goals. And some of those include the desire to improve and expand telehealth in their rural health clinic. And that includes services such as remote patient monitoring and chronic and principal care management services. They intend to explore telehealth service options to include treatment for substance use disorder, and to partner with local schools and industry to offer telehealth services in urgent and emergency situations, as well as preventative and chronic primary services. And also to reduce transfers from the ED to nearby tertiary facilities by increasing use of teleconsults with specialists. So that is just a snapshot, and a very impressive snapshot of TIPA County Hospital. And I think their Director of Quality Risk and Compliance says it best, and she says, we would not have had the resources to purchase what was needed without participating in the program. And so I think truly participating in the DRCH program has resurrected TIPA County's previous telehealth implementation efforts and allowed them to restart and succeed. So thank you so much for allowing me to present just a snapshot view of TIPA Hospital.
Thank you, Kim, and thank you, Trudy and Nikki. At this time, we want you to ask any questions that you might have, and then we're also going to kind of go over some upcoming events while you think of questions, and we're going to put a post poll up. In the meantime, we also want to you to know that, I mean, everyone that comes on here is passionate about telehealth, and the thing about it is it's happening whether we like it or not. And we know without a doubt that this thing is going to keep changing, and this is going to keep growing, and it's going to keep evolving. And so we want to be in front of that. We want you guys to have like a one-stop shop where you can say, hey, you want to know what? We're looking at this. We're at this level. Where can I go to find the information? And that was kind of our motivation behind it, as Terry had kind of mentioned earlier. It has been a great honor to work with these people and these different teams at NRTRC and the federal office. It's been a pleasure. Any updates to the guide will be posted on the center website on the link that we have put up there. And of course, we can offer, or we do offer, and are your TA people for anything flex related. So questions about telehealth can also come to us. There's the link again. And so we want to make sure that you are aware of that. The poll's up on the screen if you don't mind taking that. We do have these upcoming things coming up, including a continuation of the webinar series on telehealth on September 22nd. You guys also have some reporting due, PIMS, and the end of year report due on November 30th, PIMS on October 30th. And of course, here at the center, task November 15th, we can review a certain section of your report if you need us to, but November 15th will be the last date for that. So we want your questions. So what questions, comments, concerns, anything like that you might have at this moment? I always say questions, comments, concerns, dedications, or complaints. Preferably not complaints, but what feedback do y'all have, if any? You can come off mute or you can chat.
Hey, Matt, I had a question.
Yes.
Good to see you again today. twice in
Yeah.
one day. Hey, Kim, I wanted to ask you, so what was the process, like the period of time from like begin to finish with implementation at TIPA? I'm just curious. If you said that, I'm sorry, I missed it.
Oh, that's a great question. So yeah, so they began the program in 2017. So, and it's a 3-year program. And so, the program year runs a little bit different than the calendar year. So it's from September to September typically. So they would have started this work probably in calendar year 2018. And then so by February of 2019, they were ready to kick off before COVID, ready to kick off everything. They had done the planning and the implementation. Does that answer your question?
Yes, thank you. I was just curious.
Yeah. And hey to you.
To clarify though, Kim, they probably didn't have their telehealth assessment right away in 2017.
Right. They wouldn't have started it till probably 2018.
Okay.
Yeah.
So they really were starting from ground zero, really.
Yes. Yes. They would have been selected for the program in 2017 and probably would have started that in 2018.
Thanks, Kim.
I think a big point to be made as well is we don't have to take giant leaps when it comes to telehealth. You don't have to be tomorrow, you don't have to be 100% ready to do anything and everything telehealth. It's going to be baby steps. And some of the hospitals that you guys work with, it's just going to be baby steps. And this guide is meant to be a reference for you to kind of help them out and point them in the right direction.
And Matt, following up on that comment, it's incredibly important that they at least start thinking about this, that they start thinking, okay, we can't do all of this. We're extremely busy because of COVID, but now's the time to start considering when we might implement some of this, what resources might be available. If they're already on their way, I know that with HIT, we had a lot of hospitals that made kind of hasty decisions and then lived to regret it. So the process of choosing of vendors, extremely important. And whether or not you're ready to jump in with both feet here, I think it's extremely important that our hospitals start to think about this. And I think this guide is the perfect place to start if they don't have anything else, because it's designed specifically for them. It lays out kind of the process. It may seem really simple, but as Trudy explained, there's multiple facets to it. And again, they're going to go at their own speed. TIPA is going to go really fast. Others are kind of lag behind. But ultimately, I think we're committed to them making an informed decision, and that we have resources available to them when they need them, and that we in turn also have support for you folks when they're coming to you, or if you have any questions as well.
And the guide is full, absolutely chock full of resources. We knew we weren't going to be able to disseminate every single possible path. I mean, we would never end. So we wanted to make sure that we gave you links and connections to resources that would be updated, that you can continuously refer to. And we know, again, here at the center that this guide will need to be updated as we go on and as things turn, and whether or not the pandemic continues for 3 more months or 3 more years, hope not, but we're ready for that, and we're ready to tackle telehealth from that direction as well. And so we're staying on top of it, but we wanted to get in front of it as well a little bit and say, hey, here's your baby steps, here's your big steps. But like Terry said, be thinking about it. Think about how you can be a resource and a help to your hospitals. Does anybody have any questions or anything that you would like to add to this?
Are we allowed to unmute ourselves and ask questions, or should we put it in the chat?
No. You can totally, Lisa, go ahead.
Okay. So I'm really active with the Mid-Atlantic Telehealth Resource Center. And I just want to say, first of all, that this guide is fantastic. And with Matrix, we've been for years trying to figure out how to do something like this. So is there a sense that with the other regional telehealth resource centers that this might duplicate efforts that they've already started, or will this be complementary to other activities that have happened with the other regional centers? Or can everybody just kind of adopt this and say, yay, we have something?
Yeah, I'm going to chime in on the beginning. From the center standpoint, we hope everyone just adopts this one. You know, we worked hard on it. I'll let Nikki chime in on that as well. I think it's our understanding that there are a lot of people that are working on telehealth stuff. It wasn't our idea to jump in front of anyone or to take anyone's wind out of anyone else's sails. We knew it was needed. We did it. If anybody else does, we hope it complements well. And if they don't, we know that we have this resource as a prime resource. That would be my approach. Nikki?
Agree 100%, Matt. And Lisa, great question. As I mentioned in the discussion about the national consortium, so with the explosion of the pandemic and what that's really brought to telehealth, there's been a shift within the telehealth resource centers as well to not duplicate. You know, there are so many needs out there related to telehealth that we can't afford our time to duplicate these services. So the intent is absolutely to share and then also piggyback off other programs that have started. So feel free to let them know. We'll be sharing at our next national consortium, and we've alluded that this is coming, but we were waiting for the launch today. So great question.
And this is Mike from OAT. just to say that we are in full support of this. And as Nikki mentioned, we have limited resources, but we're also recognizing that we have to work with critical access hospitals and RHCs more. And that is one of the things that the resource centers are going to do, as well as our COEs, our centers of excellence, are also doing some work. There's a lot more leveraging within OAT itself. So this is definitely with our blessing, and run with it.
Yeah, absolutely. You know, I was going to say Mike would not let us get away with duplicating something. So, and I also just want to space special thanks to Mike, because he edited this thing really very carefully, and I was really pleased that he got involved. And as I mentioned before, the Federal Office of Rural Health Policy also had input to it as well. And so we're committed as TASC not to duplicate anything that the TRCs are doing. And even within our educational presentations, they're generally one of the TRCs is doing this. So we're working in close harmony. The resources are primarily available through the TRCs and through OAT, but we hope this adds something to the resource pool.
Exactly. And as has been alluded to, we know that this is an evolving subject. And of course, we will keep updating as we needed, either through directive from the federal level or just from things that we're hearing on the ground and things that are happening. We hope moving forward, we'll also have more case studies. There's been a few comments here that have said, hey, we're working on this in the state, et cetera. And we would love to have a whole website of just case studies on how to implement these, telehealth steps at your critical access hospital. So we will stay on top of it. Again, feel free to reach out to us with any TA questions or anything of that nature. We are at the top of the hour, so we will wrap this up. That's my doorbell that's barking, not my dogs. I'm sorry. And we will wrap this up. And again, email us if you have questions. Thank you, NRTRC. Thank you to the federal office and everyone at TASC. We really appreciate you guys. Hopefully you get good use out of it. And we'll be in contact with you guys. Thank you so much.